So just to discuss a little bit about the BRUIN study, and this was a study that looked at relapsed refractory patients with CLL who all had to have had a covalent BTK inhibitor. They were either relapsed from the covalent BTK inhibitor or were intolerant to a covalent BTK inhibitor, but 100% of the patients had to been exposed to a covalent BTK inhibitor. A subset of those patients, about 40% of them, also had prior BCL2 or venetoclax-based therapy. The results of this study show that patients who develop a common mutation that can occur after covalent BTK inhibitor, such as a C481S mutation, that those patients did respond to a non-covalent BTK inhibitor, i.e. Pirtobrutinib in the case of this BRUIN study. So excellent results in this sort of relapsed refractory population. Because of this, Pirtobrutinib is the first non-covalent BTK inhibitor. This got approved in the US in December of 2023. Due to this study, we have longer follow-up. The efficacy, it is still a BTK inhibitor. So we still talk about the same sort of side effect profiles that we do with covalent BTK inhibitors, but the frequency of these side effects seem to be remarkably low. It's very well tolerated. Obviously, it's less follow-up than some of our covalent BTK inhibitors, such as Ibrutinib, where we have 10 years of follow-up. But we now have over 3 years of follow-up from the BRUIN study. And that was updated recently at last year's ASCO, looking at the side effect profile of Pirtobrutinib in the BRUIN study. Now, fast forward, obviously, now that it is approved, there are many trials, BRUIN extension studies, so to speak, that are combining Pirtobrutinib with other agents in a time-limited approach. So now you have Pirtobrutinib with venetoclax and rituximab, versus there's a study Pirtobrutinib and venetoclax alone. And so some of the brief, updates of that study look like a very good response rate so far for a time-limited approach. And so we'll look forward to longer data with time-limited combinations of Pirtobrutinib in the relapse refractory setting. So, and even Pirtobrutinib is making its way in the frontline setting with combination trials. Again, time-limited approach. Nit and Jane had presented recently at some of the congresses regarding Pirtobrutinib, venetoclax, and obinutuzumab in the frontline setting. This is a time-limited as well. And very, very high responses and undetectable MRD. They're expanding their study at MD Anderson to include more patients to look at the overall response. But these types of time-limited approaches will certainly, I think, the question is, how will the non-covalent BTK inhibitors move up compared to the covalent BTK inhibitors? Right now, in practical settings and given its approval, most of us are giving this after prior covalent BTK inhibitor therapy. But certainly with some of these studies, there's obviously going to be a challenge in the space about which BTK inhibitor do you start with, whether it be covalent or non-covalent, and that will lead to other randomized trials. Stay tuned, comparing the two in terms of which might be better and how to best sequence these agents, going forward. Do you go from covalent to BCL2 to non-covalent, or covalent to non-covalent to BCL2? And so I think this opens up lots of different study questions and possibilities about the right sequencing. And so we'll need these studies to look at this strategy over time and get more data, which will take years to do, but which is the right approach in terms of sequencing. But stay tuned. You will see the non-covalence in time-limited approaches slowly moving up in the frontline setting as well.